Thank you very much. It's a great pleasure to be back. I had a great time here in Montreal in the last time we had this meeting. And, some of the things that Frankie said, me and Leo are very similar. I'm Greek, Leo is from Russia, so he's in trouble, the mafia. And of course, we got Guy there from Italy, so it doesn't get much better. Um, yeah, so over the years, Frankie and I built a lab that did cardiovascular imaging, as well as branching out to other things whenever it was within our interests, like neuro imaging. But every time we've had the advantage that we could concentrate on a problem that we saw that was important and where we could actually contribute something. So we've worked on everything from MR sequences all the way to CT angiography and 3D printing. And today I'm going to give you sort of an update on what's going on in the functional CT imaging for coronary artery disease. And now, whoops, which way is forward? Forward. There you go. These are my disclosures. I do get research funding from Toshiba America and Vital Images. And, I'm going to try and take you through the whole story. And, of course, as a scientist, I know there are a few clinical staff in here, so I'm going to, try to balance it out. Now, you have to go all the way back and consider that this is one of the biggest problems that we have to deal with. Cardiovascular disease is the #1 cause of death. Cancer is coming up very fast, and will probably overtake cardiovascular disease. But within cardiovascular disease, coronary artery disease is the leading cause of death. So, whoops, there we go. Right, so let's think about what the gold standard has always been considered for a very long time, and that was coronary catheter angiography, invasive angiography, where you take the patient, you inject some contrast selectively into the left and right coronary artery, and you look for a stenosis like you do have here. And you would consider that if the stenosis was pretty significant, say more than a 50% reduction in the diameter of the vessel, you'd say that this was an obstructive stenosis and that you needed to intervene and maybe put in a stent, or depending on the type of disease, go for a coronary bypass graft. Now, the problem with this patient management has always been that you ended up sending a lot of people to get invasive catheter angiograms that are very costly and also have a very small, but still significant risk. And 50 to 70% of the patients that would go to the cath lab actually did not have any obstructive disease, right? So, and this is definitely something where we can improve upon. Now, then comes, let's look 15, 20 years back, starting to think about non-invasive imaging, and coronary CT angiography comes into play, and beautiful image quality that really should give us very similar information as an invasive coronary angiogram, except with a much lower cost and lower risk. And immediately, everyone started looking into, well, what is the correlation? How does CT predict these stenoses at the gold standard invasive angiography? And everyone found what was to be expected, that it has very good agreement with coronary angiography when there is no stenosis. So if there is no stenosis, it has very high negative predictive value. If you don't see a stenosis in CT, then you can rule out coronary artery disease, which is great. However, specificity, which is there an obstructive stenosis, was not so good, and it remains so to date. But we've even already moved beyond obstructive stenosis, which is what I'm actually going to concentrate on. Now, once you had this new tool and you knew that it works pretty well, at least for saving people that don't have any disease from having to go for an angiogram, the next question, what became important in the last 10 years primarily, was, well, how can it help us optimize patient management today? Can we save money, or can we do better for our patients? And there's a couple of trials that not long ago, in the last few years, have been published, and this is PROMISE, one of the trials, another one is Scott Hart. And each one looked at, well, how can CT improve upon the management algorithm? And, to make things simple, what happened is, at least for, with PROMISE, what they found was that you could save a lot of patients from having to have unnecessary angiograms. So, whereas before, 50% of your patients would go to an angiogram and not have obstructive stenosis. Now that has dropped, that can be, with CT, that can drop to a lot less. So only 30% of the people that go into invasive angiogram actually have a non-significant stenosis. So you improve care by having fewer negative invasive procedures. At the same time, though, there was something else that was a little interesting, or very interesting, which is that more patients ended up getting intervened upon when you used CTA as the first-line imaging modality. So that kind of tells you that you found more patients that you thought needed treatment, but at the same time, you didn't decrease the number of events. So you treated more patients, but you still got the same number of events as the other standard of care. So if we take a step back, running summary is that CT rules out coronary artery disease very well, and it improves the rates of negative invasive coronary angiography. However, now, let's say you take patients that do have obstructive coronary artery disease, and you decide whether you're going to treat them medically, just give them drugs and go home, or whether you're going to perform intervention, coronary intervention. Well, it turns out that even for patients that do have significant disease, significant stenosis, you really don't have much of a difference whether you intervene or not intervene. So anatomic lesion severity really is only part of the problem that we have to deal with. And if you think about the whole thing, the whole pipeline, so to speak, you start with a heart that pumps blood, and then that blood is carried by the coronary arteries to reach the end organ, and really it's the myocardial perfusion, whether the myocardium is getting enough oxygenated blood when it needs it, at stress, at cardiac stress, at exercise, to avoid having, say, a myocardial infarction. Now, over the last decade, again, a lot of effort has been expended to see whether really does thinking about the end organ rather than the pipe that's taking the blood to that organ, does that help us do better for the patients? And in fact, if you decide who you're going to perform intervention on, who you're going to stent, based on the fact that based on being able to demonstrate that there is ischemia, patients are going to do better than if you just look at the percent stenosis and decide whether you're going to intervene based on the percent stenosis. So, and this is one of my favorite examples as being from the science side. You see this case. This is a CT, whoops. So this is a pretty tight lesion, very nice CTA, beautiful CT angiogram, and right coronary artery, very tight stenosis. And the real question is, okay, this looks very significant to me. I mean, there's a very big reduction in diameter, but does the stenosis really need anyone to do anything about it? Is it causing ischemia? So, and that question has been answered over time. And it turns out that you really can't tell by looking at the anatomy. You absolutely not ever can you tell whether that stenosis is causing ischemia. You can have a stenosis that is 90 to 99%. That's like almost only 10% of the lumen remaining, of the coronary pipe remaining. And still, 4% of those lesions will not cause ischemia. And you're better off not doing anything according to the data that we have. Now, on the other hand, you can look at a 50% to 70% stenosis, and 65% of them do not cause ischemia, but then there's another 35% that really need intervening. And even more recent data that came out of, for example, from the ripcord study, which I'm not going to talk about here, but you can Google it, found that even stenosis less than 30% have a small but still significant percentage of which are hemodynamically significant. So we're talking about a tiny reduction of the coronary lumen by 1/5, by 20%. And still, that's a lesion that you need to intervene upon. And in this particular case, we actually had the answer, and we know that this stenosis is not significant, does not cause ischemia, and you're better off just treating medically. So that's great. We know that CTA can help us, rule out cardiac disease, but what about its positive predictive value now to detect ischemia? So, of course, I just spent so much time telling you that stenosis does not predict ischemia, And that's the data that, of course, was found by everybody looking at positive predictive value to detect ischemia is very low. It's about, 30%. So you find a stenosis, not necessarily ischemia. So at this point, we know that CT can help us save unnecessary ICAs that will be negative for sure, but it doesn't help us determine who needs to actually go to the cath lab because they need to get a stent. So we're only basically halfway there. And what's the gold standard to determine whether someone has ischemia? The gold standard really comes by thinking of the pipe now going to the fluid dynamics, computational fluid dynamics, and nature in general, which says that in an epicardial coronary artery, there should be no resistance to flow in a normal one. So flow is always driven by a pressure differential, from high pressure to low pressure. That, in the coronary circulation, that should happen between the aorta and the microvasculature. No such pressure drop should occur inside the epicardial coronary artery. However, if you do have hemodynamically significant disease, that's going to change. And if you look at the pressure before a stenosis and after a stenosis, their ratio at stress, at cardiac stress or maximum hyperemia, will actually tell you whether whether that stenosis is causing ischemia if the ratio is less than 0.8. So we have a pressure ratio, distal versus proximal, and if it's greater than 0.8, it doesn't cause ischemia, we don't need to intervene. Less than 0.8, we do need to intervene. And you can measure this in the catheter angiography simply by putting a wire, not so simply, by putting in a wire that has pressure sensors and injecting the patient, giving the patient a stress agent, adenosine, and measuring the pressures in the aorta and past the stenosis, and then simply taking the ratio. So it's a simple measurement. Now, back in 2010 or so, Charlie Taylor, who was a computational fluid dynamics guy working at Stanford University, he was a professor there, he came up with an idea that was quite new, and in general in medicine, I dare say, which was that maybe we could start from the CT angiogram and figure out what those pressure drops are in the coronary arteries, just as you would do in the angiography lab. And this would be done entirely by computer, based on computational fluid dynamics. So and this is called FFR-CT, and how does FFR-CT work, really, starting from a CT angiogram? Well, you take the images, and from the images, the first thing that you do is you determine what the pipes that will carry the flow are. What's the coronary lumen? And you make a model, a computer model of those pipes. The next thing you need to do is you need to figure out how much blood needs to go inside that pipe and how much needs to come out of each one of its branches, the left circumflex and the LAD. Now, once you have those two pieces of information, which are called flow boundary conditions, you can just give them to a computer, and the computer will solve the so-called physical laws of the Navier-Stokes equations, which are the equations that determine the motion of fluid. And this solution actually is one that tells you what the flow velocity is, as well as what the pressure is. So from this solution, from the computer, you can just calculate your simulated pressure now, and from that, of course, it's just as if you had a pressure wire in that coronary system, and you can measure the ratio and calculate an FFR-CT. Now, here's where the real magic comes in. The magic is that, if you think about the computer in this model that you're making, you can put whatever values you want to it. You can say that this patient requires 439 milliliters per minute in the left circulation, coronary circulation, and maybe 86 of that goes out the LAD. Or you can say for the same patient, I just decided that really 345 of that 439 needs to go to the LAD. And that's a decision that you have to make based on only the information that you have, which comes only from the CTA. That's the only information you have. So which one of the two are you going to pick? And depending on the one that you pick, you're obviously going to get different answers. Both are physically correct. They will give you different FFR, invasive FFR values. Which one is correct? Who knows? So this is the really difficult part, and this is the only technical part that I'll show hopefully today. You know, the very first method that was developed to do FFR CT is by HeartFlow, and it's a company that's spun off by Charlie Taylor at Stanford. And they came up with their own model. And this is what I want to concentrate on, which is the quantitative physiology model. This is the trick that says, starting from this CTA, we know what to give this computer in order to solve this problem. This is what we need to give it. And this thing basically has two components. The first component goes back all the way to the 1920s. Cecil Murray and Murray's law, which said that nature doesn't build coronary arteries, or any vessel for that matter, just arbitrarily. They are built based on the amount of flow that they need to carry. So the coronary flow is proportional to the coronary diameter. And the second component is, well, to measure FFR, you need to do that at maximum hyperemia, at cardiac stress. So how do you simulate stress starting from a resting state CT angiogram? Well, for that, you make an assumption that at hyperemia, the microvascular resistance has a very specific response to adenosine. And that response is basically that in everybody, it drops to 1/4 its resting state value. Now, through some mathematics, it's pretty easy. Once you have those flows at rest, and Murray's law applies at rest, it's pretty easy to calculate what the distal myocardial resistance is, and therefore, you can simulate stress just by telling the computer to turn it down to 1/4. So that's not very hard to do. Now, maybe perhaps the bigger problem with the HeartFlow FFR CT model is how does it actually work in practice? It is FDA approved now, and it's the first method. And I said a little while ago that, you know, in medicine, I think FFR CT is a very, it's a different way of thinking, because it's the very first time that the FDA approved a computer effectively making a simulation to help you make a diagnosis. Now, of course, this is starting to change, and a lot of artificial intelligence and machine learning, you probably have heard, is being used to read CTs and X-rays, and this will change very quickly. But this really was the first time that a method like this was approved. So you start with your standard CT angiogram. You don't need to do anything else, just a standard CT, preferably, you know, prospectively gated. Then you take those images along with a fairly fat check, and you set it to HeartFlow, who takes 24 hours to do their magic. Now, they don't tell you anything about what exactly they did. You don't even know whether you agree with how they think the flow pipes look, how the coronaries look. So you might, as a radiologist, you might think there's a 50% stenosis, and HeartFlow might say that there's a 75% stenosis. You don't know that, and you can't, you have no control over that process. But 24 hours later, you'll get your answer. And it's a good model in some ways because it's easy and it's reproducible, and that's one of its major strengths. But it's bad in some other ways, and one of them being the time it takes and the cost it has. So over the last 5, 6, 7 years, there's been a number of trials that proved this technology actually in fact works, and the computer can do a pretty good job at predicting coronary flow at hyperemia from a resting CT. And the first one, which came out in 2011, and these are the plots that basically show the diagnostic accuracy. And all of those compare to CT percent stenosis. So of course we already knew that CT percent stenosis, CTA, does not have a good positive predictive value for ischemia. And that's shown by this area under the dashed curve being not covering the full graph. Now, once you use FFRCT, that becomes larger. And accuracy goes from 61 for CT to 81 for FFRCT. Now, the second trial came along, and look at what happened here. So CTA did a little bit better, but FFRCT, and this one was also more patients, it actually did worse. Accuracy was, instead of 81%, 73%. So that was a little interesting to see. And of course, a year later, another study comes out, even more patients, and this one flipped the coin. So CTA now did worse, but FFRCT did better. So of course, there's technical reasons for that, and there's sampling. You know, you're picking 250 patients, that's random sampling. So, you know, all of those things come into play. But the more important things about that say something about FFRCT and that we need to pay attention that control these numbers, at least in part, is what happens. So for the middle trial, CTA did better, in part because CTAs were read in a core lab. So experts on the subject read every CTA. On the other hand, FFRCT did worse because only 3/4 of the patients received a nitroglycerin. So no vasodilation, CTA quality is lower, and maybe that impacted negatively the accuracy of FFRCT. Now, the final trial instead had site CTA reads. So at every site, they read the CTAs. Everyone has different levels of expertise, different levels of years of experience, and so on and so forth. So that explains CTA going down. But what explains FFRCT accuracy going up? Nitroglycerin was much better. 99% of patients got it. But also, they excluded 13% of the CTs due to quality. So 13% of CTAs were not accepted for FFRCT analysis. And there was an improved algorithm involved as well. So following up a little bit on, because FFRCT is such a new technology, we only have those very few trials so far to start drawing information about what patients this can apply to and what we need to be careful about. And teasing out one of those things I already alluded to is that nitroglycerin. You can't do FFRCT unless you have a good quality CTA with nitroglycerin. So that's an important factor and statistically significantly drops your specificity if you don't do it. Also beta blockade, same thing. Now, FFRCT also had some strengths, and those strengths were that it's pretty well reproducible. So if you send the same CT to HeartFlow twice, you will get two answers that are going to be pretty close to each other by 0.01. They're not going to differ by more than that. And if you think about that, even the invasive measurement with a pressure wire, if you do it twice, not everything is going to be exactly the same. That also has a very small variability. So in these two variabilities, they're not that different. So that's good. It's reproducible. We're not going to get a different answer every time we do it. The second thing that was very interesting, at least to me and a whole lot of people that work with coronary CT angiography, is that it turned out that FFRCT did really well when you had severely calcified plaques. Now, when you have a severely calcified plaque, you can't even tell where the coronary lumen is. There's calcium blooming, there's artifacts. But yet, it turned out that not only can you compute the FFRCT on those patients, but you will actually do just as well as for those patients that don't have very highly calcified plaques. So for people with a very high calcium score, you did this solid line, and it's not statistically significantly different than for those patients that have a low calcium score. And this really is a conundrum, but that's a selling point. If you're developing a new method and selling it, that's a good selling point. But not a very well understood one, I'll say. And this data has actually seems to be confirmed now with other analyses that are showing that as calcium score goes up, CT performance degrades, its accuracy goes down because it's difficult to read. FFRCT also goes down, but not by as much. So that's a very interesting aspect that I would love to see someone try FFRCT using, say, calcium subtraction that's available on the CT, on some CT systems. So to update our running summary, CT-derived FFR answers if coronary artery disease causes ischemia, and this improves the rates not of the negative ICA, but of unnecessary ICA, and by unnecessary we mean those that do not need a stent or a cabbage. It does take a long time and it has a high cost. So one of the questions then was, just like when we first got CTA, we asked the question of how does it impact patient management. It's the same for FFRCT. And there was one trial, again, funded by HeartFlow, that tested this for patients both that were planning to go to catheter angiography based on the standard of care, as well as for patients that were going to have a functional test, stress echo, exercise treadmill, or whatever other test was being planned, and randomized patients in each one of those two cases, randomized them between having an FFRCT first and then deciding what to do versus the usual care. And now the results were pretty good, as you'd expect. For one thing, for those patients that were already planned to go to catheter angiography, in the usual care that actually did go to catheter angiography, 73% did not even have disease. That's what we expected from the very beginning. Now, from the people that got FFR-CT, only 12% ended up not having non-obstructive disease. So again, we saved a lot of negative ICAs, 61% of them. Also, cost was lower, and invasive angiography does have a much higher cost than CT. Now, for those that were planned to have a functional non-invasive test, what happened is that what you can say is that there was no difference in the percent of patients that ended up going to catheter angiography after having either their functional test or alternatively the FFR-CT. So it really didn't change the number of people that were deemed to need to go to catheter angiography. But costs were a little higher for FFR-CT, of course, since it costs $1,500 a pop. Now, importantly, however, even though there was no difference, there was also no difference in the number of events. So it's not that you sent fewer people to catheter angiography, or the same number of people to catheter angiography, or fewer people to catheter angiography, and you got twice as many heart attacks. That didn't change. Outcomes didn't change. So FFR-CT is gaining a lot of traction because it may reduce costs and improve quality of life as well. One of the bigger limitations that I see, however, with it is patient selection. If you look at the current exclusions and as they have evolved over the lifetime of FFR-CT, is that you're getting more and more and more restrictive to the point where who is it in the end, what are the patients that you can actually apply it to? So you can't have a prior stent, you can't have prior CABG, if you're too large, you can't have one. Complex congenital heart disease. But the most important one, the one I have in outer red over there, is that the quality has to be acceptable by a commercial entity. And let's see a little bit about how much of a difference that can make. So the two trials that I talked about, NXT and Platform already, they rejected 13 and 12% of the CTAs. And these were trials funded by that entity. And the problem with that is that they trained the centers to do a pretty good job with the CTA. They provided feedback, they provided training, so those CTAs were as good as they can get. And still, you have a 13% rate that you're not accepting. More recent a sub-study that was just actually published by one of my good friends and old trainees in the lab when Frankie was there, Michael Liu, who is now at MGH, was a sub-study of the PROMISE that I showed earlier. And what they did is they tried to take a set of patients and do an FFR-CT on them, and 33% of those patients that they sent to HeartFlow actually were rejected. It actually gets a little bit more interesting in that it wasn't just that 33% of patients were rejected. Michael did a pretty good job at throwing away all non-diagnostic studies. So he already went through all the studies, found the ones that were up to guidelines, so high resolution, good field of view, no missing images, good scanner, got nitro, everything was done according to guidelines for coronary CTA. Out of all those studies, 50 of them he decided were not good enough, absolutely not. Fine. And then, of those, he sent them to HeartFlow for FFR-CT analysis, and 1/3 was rejected. So at that point, you're down to a pretty small percentage. Now, there are other studies that are going to be coming out, and they're going to show probably that the results are somewhere in between. So, but this is a major limitation in all. So it is not accessible to all patients that have a good diagnostic CTA. Now, lately, in the last couple of years, there's been a push to sort of open up the black box of FFR-CT and try to make it more accessible, give more control to the radiologists and the cardiologists that are actually treating those patients and that are reading the CTAs. And the first method that came out to provide this functionality was the so-called CFFR. And what CFFR did is basically gave you the ability to perform the analysis on your workstation. So you acquire your CTA, you go to your workstation, and you perform the analysis, you do your own segmentation, you decide what the coronary stenosis is, and also it did some simplifications to make the computation much faster. So it doesn't take 24 hours, it takes 10 minutes. And the preliminary results from this were pretty good. And this is something that you can do yourself, accessible. You can apply it to all the patients that you deem can have this analysis. And accuracy was about what you'd expect from an FFR-CT algorithm, from an early version of one at least. Now, one of the things that study also, study of that algorithm showed is something that we hadn't seen from data from the previous trials on the initial technology, which is that misalignment artifact does actually affect the diagnostic accuracy of your CT-FFR algorithm. So if you have step and shoot type artifact, misalignment, then you're not going to get as good a result as if you have a volume CTA. So this is one area where volume CT can really help with FFR-CT. And these are analyses that were not possible before when a company has control of an algorithm. So there's, in my opinion, there's a lot of interest, just like I said, for calcium subtraction. Maybe FFR-CT can do better with calcium subtraction, but we won't know that until we have the ability to try it. So the most recent method came out, it's actually, the paper is still in press, and it's the so-called 4D FFR, CT-FFR. And it's from a vendor who shall remain anonymous, but thank you for lunch, right? And now this technique also wanted to do the same thing of providing a online, on-site workstation that you can perform the computation on yourself and that you can control. One difference is that it actually is no longer a standard CTA. It requires a little bit of additional CT data. Specifically, it requires acquiring up to 100% of the RR. So usually you image in diastole in your perspective CT, and you might do 65 to 80 or 85. Now you got to go to 100. Now, why do you actually do this? The reason why you do this is that it uses a completely different approach, and this is the reason why I showed the technical slide at the beginning of the FFR-CT with the coronary diameters and Murray's law, is because now this method said, well, we don't really need to go back to anatomy and diameters. Maybe there's other ways to tease out what the flow in the coronary arteries is for a particular patient from the CTA. And they do that basically by looking at how the coronary lumen changes through the cardiac cycle within that 70 to 100%. And really, this is a completely different departure than the other methods, and I think it'll be very interesting if someone can afford to do both, say, heart flow FFR-CT and this method of FFR-CT and compare and see where each one does better or where each one fails. Now, in terms of results, this was the very initial study, and it was a small number of patients. So, of course, you saw better accuracy with CT-FFR, but the statistical significance is not there yet, although I am working with other groups that have this algorithm, and these results are going to change, of course, over time, and we'll see where it settles down, and then we'll maybe be able to, at some point, compare, say, misalignment artifact versus volume CT and other things. So new CT-FFR techniques are coming, and they may improve costs, they may improve time to result, and accessibility, and also potentially incorporate better physiology models. And this is one of the things that I'm working on my purely scientific research side, where we also have a yet different physiology model, and we can show that it does much better than, say, Murray's law. So this, even though FFR-CT might be perceived as a black box, if you open the box, then you may be able to do a much better job. The last thing I want to talk about is CT perfusion. And of course, with CT perfusion, you avoid the whole situation of, you don't even, you look at the end organ. So this is, in effect, ground truth. is there a defect at stress or not? Of course, myocardial perfusion imaging and SPECT, have issues with three-vessel disease and so on and so forth, and CT perfusion probably has some of its own limitations, but one of the largest studies on CT perfusion versus the standard was the Core 320 trial of the wide volume CT, where CT angiography plus CT perfusion were tested against the then gold standards of catheter angiography and SPECT MPI. Now, one thing that I want to impress is that the protocol to get the CTA and CTP data is different. Before, when you're doing CTA, you only have the CTA component. The important part is that now you have to have a second CT acquisition. So there's more dose. And of course, there's very many different ways that you can do this. You can do the stress CTP before the CTA or after. But no matter what, you will need, ideally, you will need 2 acquisitions, at least at present. So the accuracy of CT perfusion was well established by Core 320, and it showed that it does a better job than CTA alone to detect hemodynamically significant coronary artery disease. And the reason why I wanted to talk about this in this CT perfusion is because, in CT FFR, there's 5 studies that have been done on FFRCT, and there's probably 6 meta-analyses or 7 meta-analyses of these 5 studies. And meta-analyses is a way to sort of pool all the data and figure out where you're going for real. And one of the meta-analyses that I found interesting was this one, which compared studies that had used CT perfusion versus those that had used CT FFR, and how does each one perform in terms of positive and negative predictive value for hemodynamically significant coronary artery disease. And it turns out that CTP is pretty well, even in the CT-FFR era. And this is important because CTP doesn't have some problems that FFR-CT has. It applies to more patients. You're not going to reject half your patients from it, for example. Or alternatively, as the dust settles and we figure out what's going on with calcified lesions, CTP will work even if you have a lot of calcified lesions in the coronary arteries. FFR-CT, I think the jury is still out on that point. Good preliminary results, but still out. And there is one planned study to compare CT perfusion versus FFR-CT head-to-head. So hopefully, it's not going to be a very large study, but it should give us some very good preliminary results on how these two fit together, these two technologies fit together. So CT perfusion is well established, widely applicable, does require longer scan time and more radiation dose. And you also have to inject the stress agent. But because you're injecting the stress agent, this is it. This is the ground truth. This is what's really going to happen in the patient. This is what's happening in the patient rather than a computer simulated model, which potentially can get very improved. Now, there are a couple of things that I'm very quickly going to show that are interesting. When you start having a computer give you a medical diagnosis, you can actually start asking the computer interesting questions. For example, what's going to happen if you have a stent, if you put a stent in a stenosis to treat that stenosis? And you can actually perform the same kind of simulation and figure out whether the fractional flow reserve is going to be different. And once you can do this, you can start asking, well, if I have a patient that has serial stenosis across the coronary artery, which one should I treat? Should I treat this stenosis? Should I treat this stenosis? So you can start thinking about planning your entire procedure before you go to the cath lab. So if you treat this one, this is what's going to happen to the fractional flow reserve distally. If you treat the distal lesion, then this is how it's going to change. In this patient, you really need to treat both. That may not always be the case. So there's a lot more power with these computer simulations that we can tap into potentially. So in closing, I wanted to say that there are many exciting possibilities using these computer technologies and fluid dynamics, and in every aspect, from asking how does improved CT optics or 1024 matrices affect the accuracy of these simulations? These simulations are based on a best guess that we can make about the patient. And if we have more information, higher resolution, or if we can remove the calcium and see the lumen better, then there's got to be an effect. And now we are really at a point where we can start tapping into all this power and using the computers to figure out what the best that we can do is. Thank you very much.